Next, we have Dr. Nia talking about, the topic is papilledema versus pseudopapilledema. She's a consultant at Aster Hospital.
Good afternoon, everyone. Today's my topic is papilledema versus pseudopapilledema, a clinically diagnostic dilemma. Going to the first case scenario, we have a 20-year-old female presented with episodes of hemicranial pulsatile headache, mild tinnitus, and depressive symptoms. The patient gives history of vague trauma 2 weeks back, and she was sent from internal medicine to rule out papilledema. On examination, her vision was 6/6, color vision was normal, EOM was full, no pain, no diplopia, anterior segment was normal, and no RAPD noted. Dilated fundus showed bilateral disc edema, otherwise the fundus was normal. And her BP was checked, it is normal. And her fundus showed papilledema or disc edema in both eyes, and OCT RNFL was taken, which confirmed the peripapillary RNFL thickening in all quadrants, and visual field was taken. Definitely the enlargement of blind spot was noted in both eyes. And how we proceed, we have to check the patient's BP. MRI with MRV has to be taken. Lumbar puncture and CSF analysis has to be taken. Any history of drug intake, such as OCPs or any antipsychotic drugs, anything has to be checked out. So this patient's BP was normal. MRI imaging was done. It was normal. Brain parenchyma along with mild tortuosity of the optic nerve noted. And CSF studies showed increased opening pressure and normal CSF composition. What's the diagnosis? It is idiopathic intracranial hypertension. And see how we manage it. It's by CSF drainage by LP. TAP Diamox 250 mg/BD was started, and the patient was followed consecutively, and disc edema was resolved by 2 months of treatment, which we can see in the OCT also, that peripapillary RNFL thickening has reduced. And coming to some theory part of papilledema, it is optic disc swelling, which is secondary to the increased ICP. It is the hallmark of idiopathic intracranial hypertension. It may or may not be associated with retinal hemorrhages, folds, cotton wool spots, or exudates. And the threat of vision loss it can cause is related with the severity of the papilledema. And before going to the pathophysiology, just a brush up for anatomy. The optic nerve sheath is an extension of the dura and arachnoid matter with subarachnoid space terminates 3 mm before the scleral junction. So whenever the increased ICP, it transmitted along the subarachnoid space to the optic nerve, which causes the axoplasmic flow blockage and stasis in the optic nerve head. And this can cause extracellular edema due to the swelling of the axons, as well as venous congestion causing the secondary vascular changes. Factors usually affecting the severity may be due to the degree and the speed of ICP rise, the vulnerability of the optic nerve fibers to the external compression, optic nerve sheath width and compartmentalization around the optic nerve, as well as the size of the optic disc. How to grade papilledema? It's modified Frisson grading. It's grade 0. It ranges from grade 0 to grade 5, whereas grade 0 is a normal disc. Grade 1 is a nasal C-shaped halo. Grade 2 is circumferential halo. Grade 3 is a moderate with mild obscuration of the blood vessels over the disc. Grade 4, marked papilledema with obscuration of one or more of the major blood vessels of the optic disc. And grade 5, almost all of the blood vessels over the disc is obscured. Retinal folds are seen in true papilledema, which is a circumferential papillary retinal folds known as Patton's lines, and the radial folds which are extending into the macula. With treatment, this may regress, and it is an indicator of good response to the treatment. Retinal hemorrhage may be present either with papilledema or pseudopapilledema, so we can't put it as a criteria. And causes of papilledema: expanding mass lesions, cerebral edema, intracranial hemorrhage, compression of the ventricular system in the posterior fossa, venous sinus thrombosis. It might be due to the infectious etiology as already discussed, or it might be due to pseudotomos cerebri. Coming to another case scenario, a 38-year-old gentleman who came for general health checkup with anomic aphasia, which progressed over a period of 1 month. Except deep tendon reflexes, increased deep tendon reflexes positivity, nothing was other in the systemic examination. Opthal consultation was again sent to rule out papilledema. His also vision, color vision, confrontation, anterior segment, everything was normal. And fundus showed bilateral papilledema. Immediate MRI with contrast was done, and it showed a very huge cystic lesion in the right frontoparietal lesion with causing a midline shift. Coming to the causes of pseudopapilledema, Pseudopapilledema is an anomalous elevation of one or both the optic discs without the edema of the retinal nerve fiber layer. The causes include diabetic papillopathy, toxic insult, metabolic nutritional deficiency, optic neuritis, ischemia, compression from orbital tumors and all. But all these optic neuritis and all can cause decreased vision, which is we are not seeing in papilledema. Coming to case number 3, this is a case which we have a patient presented with history of defective vision in both eyes, with right eye vision 636 and left eye 4/60, and his anterior segment examination, no RAPD, otherwise anterior segment was always also normal, and fundus was showing bilateral disc edema with hard exudates arranged in star pattern at the macula, along with tortuous vessel, arteriolar narrowing with AV cross changes, and his BP was checked, and it has turned out to be 200/110. And we have started the investigations of the patient after sending to general medicine, and routine blood examinations were normal. So the primary hypertension was ruled out as the patient's BP was refractory on treatment, and the patient was evaluated for the causes of the secondary hypertension. Case number 4, this is an incidental finding which we have noted in one patient, in which we can see a yellowish white crystal-like deposit over the disc. This is the optic nerve head drusen. It is one of the causes of pseudopapilledema. It is caused by a tight scleral canal, which causes the consecutive exoplasmic stasis and extrusion of calcium, hyaline and other proteins. Exposed optic drusen are yellow in color, and it is refractory in structure. And whenever there is a buried optic nerve head drusen, we have to proceed with the B scan to find out the increased refractivity and posterior reduplication artifact. How to skip this illusional obstacle? In papilledema, there will be transient visual obscurations and visual field defects from beam, as madam told, it ranges from enlargement of blind spot to the constriction of the visual fields. Spontaneous venous pulsations are absent. Optic disc appearance is dynamic. That means in papilledema, it will respond to treatment. Either it will worsen or it responds to treatment. There will be change in the structure of the optic disc. Whereas in the pseudopapilledema, it will be constant. Obscurations of vessel will be present on the papilledema, and hemorrhages may or may not be seen. Retinal folds are often present on papilledema. And another thing, fluorescein angiogram may show leakage for papilledema, wherein pseudopapilledema it is not there. And symptoms of raised ICP are also present in papilledema. As we already discussed, capillary leakage will be present in moderate to severe papilledema, but not in pseudopapilledema, as well as in visible drusen. IV fluorescein angiography will show a true nodular hyperfluorescence. Visual field, we already discussed, mild papilledema have no visual field defect, but in enlarged visual physiological blind spot is the first visual field defect. It is due to the subretinal fluid around the optic nerve. Moderate papilledema may cause arcuate infranasal visual field defects. With severe or long-standing papilledema, constricted visual field with central sparing can occur. Another bedside test we can use to assess this thing is optic nerve sheath diameter, and it can be used for the follow-up of ICU patients also. Optic nerve head OCT, we can see in raster OCTs, there will be elevation, inward deflection of the retinal pigment epithelium and Brooks membrane complex towards the vitreous cavity when increased IPC is present. What are the take-home messages? There will be usually no visual field deficit in papilledema. Color vision will be usually normal. Fields to be documented. Ancillary test can be done if doubtful. Patient has to be followed up with OCT scans. BP is definitely to be checked, and neuroimaging is essential for every cases. Thank you.